At Kukhan Hospital, I wanted to point this one out because, as you can see in the interventions, they didn't just focus on the HIV providers, but it involved the total facility, the whole hospital. And so the leadership got involved, the administration got involved, and there was a stigma committee formed. And I think this really, and the HA team, of course. And so this represents, I think, the approach that is a commitment to having a stigma-free institution. I wanted to also point out at Chiangdao that they realized that they needed to engage the community if they were going to address issues of access in the first place, because people were not coming to the hospital. And so in order to do that, they provided education, got involved with the families, and went out into the community and talked about the hospital services to welcome them into the hospital. They also participated in the Thai National Self-Stigma Reduction Program to help people feel more comfortable and use the health facility as a way to help overcome individual stigma. This picture, I think, is this on? Yeah. This picture, I think, just shows the total facility approach being involved and how people from the community were included in the hospital. When it comes to patient experience, we don't prescribe a specific methodology to capture the information because most facilities already have a mechanism in place for either looking at patient experience or patient satisfaction. And so there are different ways to do this. Some use surveys, some do exit interviews, some use patient forums, some use storytelling, some use comment boxes, and some use consumer advisory boards. I'm going to give you some examples, but first state that my personal preference is to get qualitative data. Surveys can give you a window on something, but we really need to probe about what's going on and understand what people's experiences are all about. So this is an example from Champasak Hospital in Laos. And here, they actually use their comment boxes very effectively. People fill them out. They open the box every week, and they review them as part of their quality improvement committee, and then address the issues, picking some that become part of quality improvement projects. When there is an individual problem, the leadership of the hospital talks confidentially to the person who's been identified as creating a problem. And so this is something that has been very successful. It was done in partnership. It was set up in partnership also with JICA, so there was a lot of involvement of Japan in the process as well. And then they identified projects as well that helped make the place friendlier. One of the things they did that was so interesting is that the medical director gave health talks on HIV and stigmatizing issues in the general waiting room for the outpatient clinic to really convey the image that this was a welcoming facility. In Vietnam, they use a number of different strategies to involve community and co-production. There are community advisory boards that are formal and dialogue with providers and jointly come up with solutions. There is a community scorecard process where there is measurement and routine ways to get patient feedback. And so examples of changes that were made in Binh Duong province included creation of after-hours services so that services were more available to people based on their lifestyles, as well as patient navigation and involving peers to make the place friendlier. We also think that health literacy, which has been talked about here at the conference, is a key element in reducing stigma. The literature is very clear that health literacy improves self-efficacy and confidence. And when people feel more efficacious and empowered, they also feel less stigmatized. And so Vietnam also had some indicators related to literacy, whether people knew when their viral load test was due, what their viral load was, and what their treatment regimen was. And they were shocked when they found that the rates were 50% and instituted a number of changes where they routinely called up people from the clinic and reviewed in a teach-back method what their data were like, so they understood what their medical situation is. One more example quickly from Malaysia because it involved COVID, and I'm not going to go through the details. Their storyboard graphics are a little complicated to follow, but I'm going to go back to the wheel in just a moment. But this is a great example where in Project Kasi at the hospital, they brought the community in to work with the providers. The community was feeling very disengaged, and it was in the middle of COVID, and so they decided to engage people from the community as healthcare workers in the clinic and find jobs for them so that they felt part of the team in the clinic. And during COVID, what they did is they helped disinfect the equipment and the wheelchairs for people who were disabled. They were taught about infection prevention and precautions, and they were fully engaged in the processes of the clinic. And this resulted in a tremendous gain in their experience and their feeling of well-being in the clinic. We have identified a number of different interventions across our network. I'm not going to read them, but just they're available. The slides will be available. And so these are examples of the kinds of changes that people can use and can be spread from clinic to clinic and then adapted as appropriate in each context of the organization. And we've just grouped these into domains related to the chronic care model. Thailand has been very active in creating peer exchange, and they've used social media platforms like Line, they've used webinars, and have meetings on site to share best practices. So another shout out here to the Thai program. So, how can we make stigma reduction a routine part of our quality improvement work? There are challenges. The measures that we use as a snapshot are not linear and affect stigma, so it takes effort and planning to put them together. We're using multiple data sources, and so we need to operationalize how we can apply quality improvement to qualitative data, not just a simple measure. We need to disaggregate our data by key populations. It's not enough to look at our overall performance rate, but we want to look at the different vulnerable groups. Once we learn to do this, we can apply it to any group, whether it's people with mental health issues, whether it's people with disabilities, people with TB. But within the world of HIV, there are many marginalized groups that give us a really good place to start. It's not easy to routinely involve patients or consumers in quality improvement activities if it's not part of the culture already, but it's critical. It's absolutely critical. And we need to understand the experience of the people who don't come back. And our methodology is based in the clinic, so we need to think about how to hear the voices of people using other partners and perhaps other people who do come to the clinic to understand why people aren't coming back. And importantly, we need to engage leadership to address stigma beyond HIV programs. We did conduct an evaluation of the network, and my colleague Dan Ikeda interviewed about 20 different members in the network, and they identified the factors that contribute to sustainability. And they cited coordination across all levels of the health system, national, subnational, and facility. Leadership support just comes out over and over again. A continuous monitoring process, adaptation so that things can be adapted to a particular population or clinic, to learn from others, a commitment to community engagement, and the relationship between providers and community. The same kinds of themes were brought out in an evaluation we did in New York. I'm not going to repeat this, but I think that there are opportunities that are very similar, but perhaps to call out the importance of identifying a focal person or a champion in the hospital who is the stigma champion, and that person helps coordinate things a bit. And so in conclusion, I can stop my timer, we believe that quality improvement can be routinely applied to stigma reduction, and we have to remind ourselves that stigma is actionable. That integration of data from both patients and healthcare workers into routine quality improvement is achievable. Ongoing data disaggregation drives effective improvement. Activities to address and assess patient experience and literacy and involving community are integral to reducing stigma and discrimination. There are strategies that have been shown to work that can be spread. Again, stigma reduction is achievable through organizational and system-level changes, not just individual interventions. Stigma sustainability in healthcare facilities requires integration with national programs and vigilance. Vigilance remains essential to address stigma continuously and promote health equity. Thank you very much for your time. Just some pictures to close of our exchange meetings. This was during COVID, and I have no disclosures, we do have funding from Gilead Pharmaceuticals and ViiV Healthcare, and we have a number of partners and so many people that have contributed their knowledge to what we have learned about stigma reduction. So thank you.